We don't think that whenever a fracture happens, so the energy that caused the fracture, it also damages the soft tissues. Okay. So when you see the fracture, when you manage the fracture, we have to address the soft tissues. Okay. So basically, when there is a fracture, it involves 5 tissues: skin, then beneath the skin there is subcutaneous tissue, the muscles, the periosteum. Periosteum is the layer of the bone, and finally the bone. Okay, so in a fracture, all these tissues are injured. So we have to think like this when during management of the fracture, whatever be it the management, be it conservative, operative, we have to think of these injuries. So the injury could be mild or severe, like a fracture morphology. It could be very mild soft tissue injury or very severe injury. So, like in anatomy, you have read about the dermatomes, the nerve supply. Similarly, in skin, there is particular angiosomes. Okay, the skin, there is a very discrete areas of skin, overlapping areas of skin, they are supplied by particular arteries. So skin receives blood supply from the muscles, from the perforator arteries. So all are interconnected. The blood supply. So muscle is the surrounding tissues, they are the best friend of bone. So they are in a symbiosis relationship. Okay. So the bone, they derives the blood supply from the surrounding tissues, from the muscles, from the periosteum. So in the bone, the outer third, roughly the outer third of the bone, they receive blood supply from the periosteal vessels. So how do they arrive to the bone? Through the attachment sites of the ligaments and fascial attachment. So naturally, see, these attachments are important. So if the bone is devoid of all the tissues, then naturally the outer third will suffer. So periosteal blood supply is important. And the inner two-thirds, you have read about Haversian systems, this arterioles, canaliculi. So the inner two-thirds is supplied by endosteals. So whenever a fracture happens, there is a hematoma. Okay. What are the stages of fracture union? There is a hematoma, then granulation tissues, then soft callus and hard callus. So there is a hematoma. Whenever there is a fracture, as I told before, there is disruption of the tissues, disruption of the periosteum. So naturally, all the arteries are disrupted, all the periosteal arteries, all the endosteal circulations. So naturally, there is a hematoma. So, কেন হচ্ছে এটা? এখান থেকে হচ্ছে কি আমার কাছ থেকে হচ্ছে কি এটা? So gradually, with the healing of the fracture, these tissues also heal, these arteries forms, and they also resume and they also repair itself, and this naturally supply the bones. So stability of the fracture is really important if we want the soft tissues to heal. Okay. So if there is a fracture is not stable, then the healing of the tissues and bone, they will suffer. So as I told, the muscle is the best friend of the bone. Why? Because it provides the blood supply. Muscle is important for our locomotion, and it improves blood drainage and of the dependent areas. Okay. So all these layers, skin, muscle, subcutaneous tissue and periosteal. So these are protective of our skeletal system. Skin, this is a natural barrier to infection. If it is a closed fracture, so it is, the skin prevents infection. But if it is an open fracture, fracture is communicating to the outside environment. So naturally it is prone to infection. The muscle, it is important for the blood supply, for our movement. The periosteum, it not only supplies blood to the outer third, but it is a source of osteoprogenitor cells. And this is important for the healing of the bone. Okay, for the callus formation. So these osteoprogenitor cells, they naturally differentiate, they form the soft callus and that remodel to hard callus. So periosteum serves these two important functions. So we have to protect the periosteum, we have to protect the soft tissues. So fracture, never think it as an isolated thing. You have to protect the tissues, you have to treat the tissues. So as a general rule, a bad fracture means bad soft tissue injury. If you think that is a simple transverse fracture, it is a low energy fall, that means tissue injury would be less. And if it is a comminuted fracture, it has multiple fragments, very bad fracture. So naturally it will have large soft tissue injury. But that is not always true. Even a simple fracture could have a bad tissue injury. Suppose it is open fracture, it is a contaminated wound, it is a farmyard injury. So it is not always true, but generally if it is a comminuted fracture, that means the tissues has been damaged very severely. So naturally a bad fracture is grossly displaced fracture, comminuted fracture. So it should give you some kind of idea. If you see this kind of X-ray, that is a grossly displaced fracture. That means the tissues could have been grossly damaged, severely damaged. It could be open fracture, or if not open, the tissues, they have been damaged and there could be gross swelling or other kind of compartment syndrome. I will come to this later. This is a complex thing because, depending on the mechanism of trauma, we have this kind of fracture. So we generally divide fracture into two types, low energy fracture and high energy. What does low energy mean? Suppose a fracture, you sustain a fracture by a simple fall. In a very old people, osteoporotic individual, okay, those who have a very low bone mass, they sustain this kind of low energy fracture. Okay, so low energy fracture means the energy, that is a nature of trauma, is very less, the energy is less. So that means the fracture is very simple type. Okay, so naturally like with this kind of spiral fracture, oblique fracture, transverse fracture, they generally not always, it's low energy fall or low energy trauma, they have a less severe tissue injury. But on the other aspect, a very high energy fracture, suppose road traffic accident, fall from height, okay, or any kind of similar very high velocity trauma, high energy trauma. So in these cases, we get this kind of butterfly fragment, multiple fragment, okay, comminuted fragment. So they have generally very high grade of tissue injury. Okay, this kind of segmental fracture, fractures multiple places, they suggest this is a high energy trauma. This kind of fracture happens with a motor vehicle accident, fall from very high height, okay, fall from mountain or tree. So this kind of high energy fracture pattern generally have very high grade of soft tissue injury. So you don't need to remember all these things, just remember fracture could be high energy, low energy, and it could be closed fracture or open fracture. So what is the closed fracture? If the skin or tissue overlying the fracture near the fracture is closed. So that means the fracture is not communicating to the outside environment. So that is a closed fracture. Why this distinction is important? Because the treatment principle is different between closed fracture and open fracture. Why? So closed fracture, there is as I told before, the skin muscles, they are a barrier to infection. So in closed fracture, there is no puncture wound, the fracture is not communicating to the environment. So it is protected from the outside organisms, infection. So in these cases, we need to optimize the function, and we have to promote the fracture union and protect if we operate or if we manage with plaster, so there is a chances of infection less. But on the other aspect, open fracture, there is, or previously it was called compound fracture. That means that there is an open wound or break in the skin near the fracture. So the fracture environment, that is a sterile environment, that is now communicating to the outside environment. So naturally what happens? It is very prone to injury, prone to fracture, prone to infection, and our priority should be prevention of the infection. Okay, so all the tissues, bones, and unhealthy contaminations, they have to be cleaned out. We have to stabilize the fracture. And why this distinction important? In closed fracture, we have this Sarnu classification for the tissue injury. Whereas in open fracture, we have Gustello-Anderson classification to grade the tissue injury. Okay. So, these two are different classification system to grade the extent of the tissue injury. So, what are these? So, this is the popularly known as, this is a German name, Chernow classification. They have a 4 grades. Okay. So, this is a closed fracture. This classification is employed commonly for the closed fracture. Yeah, they have a different classification for the open fracture, but mainly it is employed for the closed fracture. So, in general, if it is a grade 0, that means the skin, so this is the bone, okay, the tibula, fibula, okay. You know, so this is a leg bone. So, all the skin and tissues, muscles are intact. There is a, though there is a fracture, but there is a no tissue injury as such. In grade 1, there is a superficial abrasion some on the skin, but this is, skin is not punctured. Remember, this is a closed fracture. Only superficial abrasion is there. In grade 2, the abrasion is deep. That means it goes deep and involves the muscles also. There is a more swelling. Clinically, you see, higher the grade, you see more swelling even, and in grade 3, it is more extensive. It involves the larger portion of the, so larger portion of the limb. Though it is a close, but the underlying muscles are grossly damaged. Okay. And importantly, it could have a compartment syndrome. So, higher the grade, clinically there could be more swelling. So, more swelling can lead to compartment syndrome. Sorry. And also, please notice, higher the grade, higher the more severe fracture pattern. That means higher the nature, velocity of injury, higher the energy of fracture. See, a simple transverse fracture, but in grade 2 and 3, it is a segmental fracture, and 3, it is a multiple level. Okay. So, more complex fracture pattern generally implies higher grade of tissue injury. So, these classifications, they are important for your exam, also for your PG preparation. So see, this is a only simple abrasion. It is a closed fracture, skin was not punctured, but this is a bit of deep abrasion is there. So, it could be grade 2 and 3. And on the other hand, for the open fracture, we have Gustello-Anderson classification. Please do remember, and every line is important. Every line is important for your PG preparation, for your question, answering question. So, everything is important. It has also a 3 grade, grade type 1, type 2, and type 3 has A, B, C. Okay. So, please understand, and if you have any doubt, ask me questions later. So, in type 1, so first thing, it is open fracture. That means the skin, the barrier is broken. Okay, there is a puncture wound or a larger wound, and the fracture is communicating outside. So, in type 1, the wound size, the laceration size is less than 1 centimeter roughly. Okay. So, naturally it is a low energy injury, and the fracture pattern would be simple fracture pattern. Okay. But in type 2, it is a bit higher grade injury. Laceration size is more than 1 centimeter. Okay. There is site comminution is there. That means comminution is fracture comminution. That is, fracture is more severe variety. Now, in type 3, and type 3 is classified, okay, this is a higher grade of injury. So, generally they have a laceration size of more than 10 centimeter. Okay. So, it is less than 1 centimeter, type 2 is more than 1 centimeter, and type 3 is more than 10 centimeter. But there is a catch, that is important. Not if size is less than 10 centimeter, does it mean that it is belong to type 1 and type 2? No, that is not always true. But generally type 3 has size, the wound size is more than 10 centimeter. Now, what is different between 3A, 3B and 3C? Important, 3A, all are high energy injury, right? 3A has, though the size is more, laceration is extensive, but the bone periosteum is not exposed. Okay. So, they have a adequate soft tissue coverage. Okay. And yeah, it is a comminuted segmental fracture. That means, though it is a large, you can close the wound and the bone is not exposed. In type 3B, it is more severe, extensive soft tissue stripping, inadequate cover, the bone periosteum is exposed, in type 3B, you need some kind of plastic surgery intervention to cover the wound. But in type 3A, you don't need this kind of intervention. Now type 3C, this is very important. It could have all these features plus vascular injury. So if a fracture, if a limb has vessel injury, naturally it goes to 3C. Okay. So if the wound size is less than 1 centimeter, doesn't matter. Okay. It is a low energy injury, doesn't matter. But if that has a vascular injury, okay, suppose if after a fracture there is a complete vessel laceration, it could be upper limb, it could be lower limb, okay, there is a pulseless limb. So that naturally goes into type 3C and that requires a vascular repair. So with this picture it will be clear. So grade 1, so it is open injury, see there is a break in the skin, simple fracture pattern, not high energy, the size is less than 1 centimeter. Grade 2, it is more than 1 centimeter size, okay, and the fracture pattern is bit higher, it could be transverse or bit higher energy. Now grade 3, more than 10 centimeter wound, right, laceration size is more than 10 centimeter. Now in grade 3, there are 3 varieties, 3A, 3B, 3C. 3A is, though the size is large, but and the fracture is that, see the 2-level break, that means fracture is comminuted or segmental. So it doesn't need plastic surgery coverage. 3B, bone is exposed. Bone exposed, that means the periosteum has been damaged. So if you simple rule to remember is, if the periosteum is exposed, that means 3B. If the vessel is injured, that means 3C. Okay. So 3A, higher energy injury, tissue is injured but bone is covered, not fully exposed. Once the bone is exposed, that means the periosteum has been damaged, that goes to 3B, right. So this size is 1 centimeter, more than 1 centimeter, so it goes into type 1 and type 2. And type 3, I am really focusing on type 3, it is always high energy injury, type 3A. If the skin defect requires coverage, okay, I told before that with large amount of periosteal stripping means 3B, and if there is vascular injury, it goes to 3C, okay. And but this last line, 3A, if the size is less than 10 centimeter, but if it is a shotgun injury, very high energy ballistic missile injury, or blast injury or farm-yard injuries, those have a fracture with very severe contamination from the wound, they are 3. So size doesn't matter always. Why? If it is a contamination, very high energy open injury or farm-yard injury, though the wound size is less than 10 centimeter, but see here the wound size is less than 10 centimeter, right, but you have to always see the fracture pattern. It is a ballistic missile injury. See metal parts are you are seeing. See the fracture pattern is comminuted, grossly comminuted. So it is not type 2 or type A. It is naturally type 3. Okay. Now plus, had there been an exposure of the bone is outside, periosteum is damaged, it could be 3B. Plus, if there is a vessel injury, this is the femur bone. If there is the injury of the femoral artery, popliteal artery, so it is 3C. Okay. So this is a thing, this is the way to remember this thing. So always you have to see the nature of the injury, how it happened. It is a simple fall, motor vehicle accident, that means high energy injury. So always history is important. Again, you are learning from the first year, history is important. Why? Because you have to inquire about how the fracture happened. What is the mode of trauma? Is it a simple fall or it is a high energy injury? Is it a ballistic missile injury? It is a motor vehicle accident, fall from very high height. So that gives an indication about okay. So this, if the patient comes with a very high velocity motor vehicle trauma, so that will give you idea that okay, this patient might have a very high velocity trauma. Then see the size of the wound, see the contamination with very dirt, pollution, and then see the X-ray, and then classify the the Gustulo-Anderson classification. Okay, one thing is to remember is this could be a question. So suppose a patient comes to you in emergency and you see this kind of picture. So, and your senior comes to you and they ask, what is this kind of classification? So you are seeing the patient for the first time. So would you classify that time, or would you do something, intervention, then classify the tissue injury? So remember, the Gustulo-Anderson classification, you do classify the tissue injury, the open wound, the classify after doing the first debridement. Okay, so once you clean the wound, then you can assess the extent of the tissue injury. Then only you can classify. Okay, so the classification is you have to do after you do bit of debridement and cleaning. So this point is important. And finally, in tissue injury, this is the most devastating complication, compartment syndrome. Okay. So bone will come later. First you have to save the limb. First is save life, then save the limb, and at the last you manage the fracture. So in this direction, saving the limb, compartment syndrome is important. What is compartment syndrome? So you have to understand. So this is a leg. This is a tibia, fibula. This is a leg, axial section of the leg. These are anterior compartment muscles. These are posterior compartment muscles, and these are all neurovascular bundle. So suppose a fracture happens. So there is naturally swelling. So what happens if this is a closed space? The skin is there. Then closed osteofacial compartment, different compartments are there with different fascia structure. You have read all these things in anatomy. So if once there is a fracture, there is a hematoma, swelling, so naturally the pressure will rise within this compartment, right? So if the compartment pressure, that is a interstitial tissue pressure, that is more than the rise to a threshold, that it compromise the blood supply to the limb, then it can give rise to compartment syndrome. Okay. So it is an emergency because it can give rise to lots of complication. I will coming to this later on. So this is a artery end, this is the venous end. So what happens? There is a flow from arteries to arterioles, capillaries to venous system. So if there is suppose this is within a leg. So if the compartment, so there is a AV gradient and blood flow from this area. But if there's after a trauma, it could be because of trauma or because of other conditions, I will tell you later. So if the tissue pressure is increased, it is a closed space. So what happens? It compresses the capillaries and it disrupts the blood supply. So if the blood supply disrupted, what happens? The tissue ischemia. So this is a vicious cycle. Why? So once there is a tissue ischemia, what happens? It damages the tissue. There is release of the cytokines. We have read about gangrenes and all these things. So there is cytokines, inflammatory mediators that damages the tissues more, and it causes release of all the cellular materials in the tissues. So it gives rise to more swelling. So once there is ischemia that damages the tissues, it further increase the tissue pressure, and this is a closed space. So once there is a compartment syndrome sets in, it propagates itself. Okay, the more the ischemia, more the tissue injury, more the swelling. Time is very important. Why? So these are roughly an estimate. So as a general rule, if you see a compartment syndrome, okay, so if it is more than it lasts, the blood supply, disruption of the blood supply lasts more than 6 hours, it could damage the muscles and nerves irreversibly. So before that irreversible damage, you have to intervene. Okay. So this is roughly 6 hours. So there are multiple, fracture pattern where this kind of compartment syndrome happens. But the most importantly, you see in the tibia, in leg bone fracture. You can also see in forearm fractures, in supracondylar humerus fracture. But in general, it is most commonly seen in a lower leg. Even an open fracture can also get compartment syndrome if there is a more tissue swelling. And it is not always trauma that can cause compartment syndrome, because any kind of disease that give rise to, that increases the compartment pressure. What could be those kind of complication? It could be after operation. Suppose osteotomy, you operate someone, you close the wound and there is a gross swelling, and the swelling is so much so that it can give rise to compartment syndrome. It could be after burn, it could be because of the nephrotic syndrome, hypothyroidism, snake bite, nephrotic syndrome, leukemia infiltration, even some kind of allergy. So even after exercise. So all these conditions, they have a potential to give rise to compartment syndrome. However, it is most commonly seen after trauma, after fracture. So the time is very important. Why? If you think that patient, if you see a patient in the emergency department, okay, this is very important. If if it doesn't matter if you are a final year or a doctor, or eventually you will be a doctor, but if you are an orthopedic surgeon or not, but as a, once you are a doctor, you have to always remember that whenever you see this kind of patients after trauma, if you think that this is a compartment syndrome and this patient needs to go to the ward, that means this patient needs to go to the ward. There is no doubt. Okay. So important thing is physical examination. Yeah, there are different kind of devices that can measure the compartment pressure, but they are only adjunct. They are not your clinical decision is important. So these are the classical signs. You can read it like 5P or 6Ps. The most important, sequence it has been given. The pain on passive stretching or pain out of proportion to the nature of injury. Suppose this is a simple tibia fracture, low energy form, tibia fracture, transverse fracture. But this patient is having severe pain even after giving analgesic. The pain has not been relieved. That means something is fishy. That time it should give you some indication that it is not okay. Pain should have been relieved. So pain out of proportion to the nature of injury, or pain not relieved with medications, or pain on passive stretching. What is passive stretching? Suppose this is a tibia, okay, leg. So this is anterior compartment muscles and this is a posterior compartment muscles. Okay, this is a posterior anterior. Suppose there is a compartment syndrome on the posterior compartment. Okay, so passive stretching means you are dorsiflexing the ankle. So it stretches the posterior compartment. If you suspect compartment syndrome on the anterior aspect, you plantar flex the foot. Okay. So if that give rise to severe pain, that means something is wrong. Yeah, there is definitely swelling, pressure. Swelling is very tense. It is not simple swelling. Once you touch it, you think, okay, this is a very tense area. Then paresthesia. Eventually paresthesia will happen because it not only damages the blood vessels, it damages the nerves also. Because for survival of the nerves, they also need blood vessels. You have read now that term. Every nerve has some accompanying blood vessels, right? So they are damaging those things also. Then paralysis. Okay, so eventually if it is a prolonged, then it irreversibly damages the nerve. In leg, it could be peroneal nerve or anterior tibial nerve. In here, it could be median nerve. Okay. So the limb, the part that has been affected, so there could be paralysis, pallor. Okay, the normal, pinkish that appearance could be, there could be pallor, and pulselessness. Okay, so always remember, though the compartment pressure is more and it is disrupting the blood supply, but pulse could be there. Okay, it is hampering the arterioles and capillaries. But so the last point, even if you are suspecting a compartment syndrome, please do remember, but if you on clinical examination you are seeing that, okay, this patient has pulse, that doesn't exclude compartment syndrome. Okay, so pulse could be there, but the important thing is these signs. So these are late findings. These two are important. Once their pulse is absent, that means you are done. It is beyond salvage. Generally, that means the damage has been irreversible. The muscles and nerves and they have been damaged. Okay, so there are different devices, okay, that can measure the compartment pressure. There is a, okay, so it is not a static measurement. Most commonly we measure the patient diastolic blood pressure and the compartment pressure. If the change is less than 30 millimeter mercury, we can suspect the compartment syndrome, okay. But again, these values, this measurement, they are only adjunct, okay. If you suspect a compartment syndrome, that means it is a compartment syndrome and you have to intervene, because you have to save the limb. Suppose you are in a dilemma that, okay, patient operation chai thak dorkar nei, but subsequently it turned out to be a compartment syndrome, then you have lost the critical 6 hours time. So initial treatment, if you are suspecting syndrome, so just think logically, what would you do? Suppose a patient comes, there is a gross swelling of the leg, or so the first thing you will do, you will remove all the tight dressings and in cast paddings. Even a simple gauze dressing, even simple cotton wrapping or crepe bandage, you will remove it immediately, because everything that is encircling the limb, they are compromising the blood supply. You always, naturally you will observe very closely, keep the limb elevated, but not too much. It should be at the heart level, okay. And you give the patient oxygen, because you need to, you need that muscles and nerves to get oxygen to saturations. And importantly, you have to correct the hypotension. If a polytrauma patient, he has lost of blood, you have to treat the hypotension, because then there is a gradient, EV gradient. If the systolic blood pressure is less, so naturally the blood supply, that less amount of interstitial pressure, they will disrupt the blood supply. So the important treatment for the compartment syndrome, or suspected or confirmed, see the line. If you suspect it is a compartment syndrome, then go for the fasciotomy, okay. So one incision, one scar mark, that is better than losing the limb. A compartment syndrome, if you can't fail to diagnose, it can cause amputation, okay. So suppose you are giving the patient only one incision if you operate, but if you don't operate, that can cause amputation. So why your clinical decision is important. So if you think you have to do it, just do it, okay. So see this kind of the tissues, see the tissues, they are grossly swelling, there is blisters. Blisters means the pressures are very high. So make an adequate incision. There is no scope for a short incision. Whichever compartment you are decompressing, you have to make a very long liberal incision. See, the muscles are black, that means it has been damaged, okay. So always, this is a very small incision, always make a liberal incision, decompress every compartment. Yeah, after decompressing, do not close the wound. There are the various ways to closing the wound. It is the vac machines or different ways of cleaning wound. And I am, these are the sequence of compartment syndrome. That compartment syndrome that you fail to manage or fail to identify and fail to treat. What are these? It could lead to infection, permanent paralysis, neurological injury, chronic pain. If there is a fracture, naturally the tissue is not healthy, so non-union, even amputation. And this area, VIC, Volkmann ischemic contracture. Okay, so what happens if a compartment syndrome is not it is not managed? Suppose there is a compartment syndrome of the forearm after a supracondylar fracture. So what happens? After it causes irreversible injury to the muscles, they are replaced by the fibrous tissue. The fibrous tissue is not stretchable, so they gives kind of deformity. Yeah. So this is called Volkmann ischemic contracture. So there is a different class, maybe in a clinical scenario, we see this kind of patient. Even simple forearm fracture, sometimes many surgeons operate forearm fracture, they close the wound very tightly. Some young patients, they return with this kind of deformity, okay, and this is very debilitating. In a young patient, this kind of deformity that is not fully correctable, and all the muscles, they are fibrotic and the function is really compromised. So we have to avoid this kind of complication. Again, in summary, the clinical signs and symptoms are the mainstay. Just remember the pulse. Pulse is the absence of pulse is the very late sign. Don't rely on the pulse. And pressure measurement, it is just an adjunct, but importantly, you have to clinical signs are important. And treatment is always fasciotomy with complete release. So you will be a surgeon after internship. You will have to deal with tissue. You have to handle the tissues. You have to suture wounds, or maybe in later on once someone you become a be it any kind of specialty, orthopedics, general surgery, plastic surgery, gynecology. So remember simple things that are important for when you handle the tissues. Incision. So many people boast that this is a minimally invasive incision. This is not always good. Why? Because in orthopedics, small incision are not always good. Small incision means you have to retract very hardly to to get adequate visualization. That basically dangerous and that damages the tissues more. So small incisions, they are not always good. Always incise the skin perpendicular to the skin, not obliquely. Retraction, it should be gentle, like you handle the egg. It should be very gentle, not very forceful retraction. That's why small incisions are not always good. It should be gentle retraction. You have to relax intermittently to keep the tissue perfused. Forceps, do not very delicate tissue, do not squeeze it very hard, okay, because it crushes the tissues. These things are really important in some areas where in orthopedics, in some areas there is a blood supply is very crucial, like in the heel, ankle area. So even we use non-tooth forceps. Tooth forceps, they crushes the tissues. Dissection, it should be sharp dissection, not blunt, okay, like it should be whenever possible it should be with the knife rather than scissors. Scissor basically that crushes the tissues, that damages the tissues. So it should be sharp dissection, okay. The developing a plane between the skin and subcutaneous tissue too much, it dangerous, because skin receives supply from the underlying muscles. So if you develop a plane between the skin and tissues, that cause more harm to the skin. So these surgical principles are important for any surgical specialty. And for orthopedics, bone exposure, you have to preserve the periosteum. Whenever you are fixing the fracture, be it with a plate or K-wire, you have to preserve the periosteum as much as possible, because periosteum is important for the, one is blood supply, two is for the bone healing. It has osteoprogenitor cells, okay. And whenever you are manipulating the bone, it should be very gentle. It's not that bone is very hard tissue, so you can do anything. No, it is a living tissue, so you have to treat it like a living being. So the soft tissue is important for the biology. It is the root of the, if bone is the tree, it is the root of the tree. And always respect it for the better outcome. And compartment syndrome, do not miss it. So always you have to respect the tissues, okay. If you respect it, naturally mutual respect is the thing. If you respect it, they will respect you, okay. So that's it. Now tell me if you have any questions. So these topics are important. Compartment syndrome especially, classification of the wound, closed fracture, and Gustulo-Anderson classification. These are important. Understanding the Gustulo-Anderson types. Again, the size is not important. Important is the tissue damage, the type, the morphology of the fracture, underlying fracture, the exposure of the periosteum, and whether the vascular supply of the limb is intact or not. These are more important than only the size of the wound. And compartment syndrome, it can happen even after simple burn injury, nephrotic syndrome, any kind of injury after fracture. So you have to identify it. There is no chance of delaying, okay. This is an surgical emergency, okay. I hope you got something positive. Kono question? No questions. So you go home, you read the classification types. Again, if you just Gustlo-Anderson is important. It because it is also for your final year examinations, PG examinations, and if someone is, you take orthopedics, these concepts are important. Every line of Gustlo-Anderson classification, these are important. Okay then, thank you.